ओके ओके
मैं कंफर्म करता हूँ सर लाइव हुआ कि नहीं।
ठीक है,
ओके सर।
लाइव है।
जी सर।
ओके, डन, थैंक यू,
थैंक यू सर।
thank you. Hello guys, I guess I'm live. There were some technical issues sorted now, so we'll start with the session. So we will be covering the topics which are primarily either directly lifted from previous year questions or the previous year topics. There will be around 25 to 30 extremely important questions which I consider relevant or important for the upcoming FMGE exam. Now I'm not going into the detailed discussion of the topics because this is a quick revision of important questions before the exam. So we will restrict to questions and the key take home messages on each question. So let me start with the first question. Here is a question. A young patient complained of fatigue and recurrent syncopal episodes. Holter was done and a 24-hour ECG recording. A snapshot of that is given in front of you. Please take a look at the ECG. What are the complaints of the patient? Complaints of the patient are fatigue, recurrent syncopal episodes. Now both of them indicate reduced cardiac output, right? So they may be pointing towards decreased cardiac output. Now we know the formula for cardiac output, right? What is the formula for cardiac output? Cardiac output equal to stroke volume into heart rate. The cardiac output can come down either if I decrease the stroke volume or if I decrease the heart rate. That is a possibility, right? Then decreased heart rate is a possibility, and to evaluate what could be the reason for that, they have done a 24-hour Holter ECG recording whose snapshot or a small bit of that 24-hour recording is given here. They are asking you what is the treatment for this patient, right? So now whenever I think of decreased cardiac output in such questions, the first thing that I should be thinking of is bradycardia conditions, right? And when I look at the ECG, what I notice here is that there are long areas of absent electrical activity, right? There is no electrical activity happening here. Neither I see any P wave nor I see any QRS complexes. Otherwise, when you look closely, the other complexes do have a P wave, right? P wave is there in other complexes. It is not a condition with absent P waves, but intermittently you have no electrical activity. Now what could be this? What is this? This indicates that the sinus node, see, if sinus node works, P wave will come, right? But here I am not seeing any P wave. If P wave is there but QRS complexes are not there, that means it is a AV block. But if P wave itself is not there, then the problem is in sinus node, right? So this condition represents the sinus node dysfunction or sick sinus syndrome. Sinus node dysfunction or sick sinus syndrome. If patient is having bradycardia, which is symptomatic, then the best way to treat that is to put the patient on pacemaker. So as Vasant commented, the treatment for this condition would be to put the patient on a pacemaker, right? So that's the answer for this question. So if there is a direct question asking you what is the treatment for sinus node dysfunction, go ahead with the pacemaker. Or if they give you a ECG or a clinically oriented question like this, again the answer would be pacemaker. Okay, now second question. Which of the following will not have this presentation that you see in the image? Now what do you see in the image? In the image we notice that there is redness of the palms, right? So we call this as palmar erythema. Palmar erythema. Now there are two conditions where you might get palmar erythema. One where there is vasculitis, where there is inflammation of the blood vessels, and second when you have hyperestrogenemia. When you have hyperestrogenemia, when estrogen levels are high, that can also cause palmar erythema. Okay, so pregnancy is a condition where you have elevated estrogen levels, so that can be a reason. Now in cirrhosis also there is hyperestrogenemia. Why hyperestrogenemia in cirrhosis? Why hyperestrogenemia in cirrhosis? Because in cirrhosis the testosterone gets converted to estrogen. Testosterone gets converted to estrogen. Rheumatoid arthritis may be accompanied by vasculitis, and that is why you can see palmar erythema in rheumatoid arthritis also. So obviously the direct answer would be hypoestrogenic state. Hyperestrogenemia causes palmar erythema. Hypoestrogenic state would be the answer here, right? Okay. The next question, simple repeat question from the previous year topics. Comment on the position of the pacemaker lead in the given image below, right? So what we see here is a patient of some cardiac dysfunction who has been inserted with a pacemaker. We can see the battery pack here, which is generally inserted in the subclavicular fossa, right? And we can trace the lead. Now this lead has entered into the right atrium. So probably they started with the subclavian vein, then into the superior vena cava to the right atrium, right ventricle. And where is the tip positioned? Tip is positioned close to the apex. So obviously if it is positioned close to the apex, apex is part of your left ventricle, right? It is part of the left ventricle. So for this question, the answer would be, this is a single chamber pacemaker involving the pacing of left ventricle. You can also have dual chamber pacemaker where the lead will also be placed in the one of the atria and one of the ventricles. Okay. Now the third question. A 25-year-old patient presents with complaints of chronic diarrhea, fatigue and tiredness. On general physical examination, the findings shown in this image is given below. Now what findings do you see in this image? Look closely to the patient's nail, right? What is the finding here? Don't you feel that the nail looks like a spoon-shaped nail, right? What we call as 𝐒𝐿𝐂𝐈𝐀𝐿. So this is a spoon-shaped nails called as 𝐒𝐿𝐂𝐈𝐀𝐿. 𝐒𝐿𝐂𝐈𝐀𝐿. Now in what condition we see that? Right, we see that in patients with iron deficiency anemia. Now please remember that there is one stage before 𝐒𝐿𝐂𝐈𝐀𝐿 becomes, right? Normally when we look at the nails, there is a slight dome to the nails. First nail becomes flat, right? We call it as platynychia. As the time progresses with the iron deficiency, it becomes like concave. Then we call it as 𝐒𝐿𝐂𝐈𝐀𝐿. So platynychia and 𝐒𝐿𝐂𝐈𝐀𝐿 both are suggestive of iron deficiency anemia. Platynychia is on the milder side. When the iron deficiency is much more severe or much more long standing, it becomes 𝐒𝐿𝐂𝐈𝐀𝐿. So obviously this patient's symptoms are probably related to iron deficiency and the treatment would be iron supplementation. Simple, right? Okay, now next question. Now we all know that every FMGE exam has one question from the ABGs, either simple or complex, and we should be able to answer them. So now look at this ABG and tell me what is the diagnosis. pH is 7.2, right? So what is the normal range of pH? That is 7.35 to 7.45. So in this question, it is less than 7.35. 7.2 is less than 7.35. So when it is less than 7.35, we would be putting it under the acidosis. If it was more than 7.45, we would have put it under alkalosis. So now we clearly know that this is a case with acidosis. The next step is to identify whether it is metabolic or respiratory. For that I have given you the simple mnemonic ROME. Respiratory, opposite, metabolic, equal, right? Now what opposite we are talking about? We are talking about pH and PaCO2 or PCO2, whether they are in the same direction or opposite direction. Here pH is decreased, it is less than 7.35. PaCO2, the normal range of PaCO2 is 35 to 45 millimeters of mercury. Here it is 68, that means it is increased. It is increased than the normal range. Now both of them are in the opposite direction. They are facing each other. They are not in the same direction. So when they are in the opposite direction, it becomes respiratory, right? So now what is this condition? It is respiratory acidosis. Next question is, should I call it as compensated respiratory acidosis or uncompensated? Respiratory acidosis. Yes, to call it as compensated or uncompensated or partially compensated, all you need to do is look at the pH. See, if your lungs are not able to clear carbon dioxide retention is happening. Now to keep the pH back to normalcy, the bicarbonate would increase. If the bicarbonate has sufficiently increased, then this increased bicarbonate will pull the pH back to the normal range. So if the pH is back to normal range, then it is fully compensated. Now in this case, can I call it as fully compensated respiratory acidosis? The answer is no, because the pH is not back to the normal range. The same EBG, if I say that the pH is 7.38, PaCO2 is 68 and bicarb is 26, then it would become a case of respiratory acidosis fully compensated. Here the compensation is only partial, right? It's not completed. So in that case, what should be my answer here? Can I go with option A, B, C or D? It is the respiratory acidosis which is partially compensated. Option B would be the correct answer to go here. Okay. Next question. So here we have a 50-year-old who comes with complaints of fatigue and limb weakness, especially in the evening. So there is diurnal variation of weakness. His symptoms improved after administration of edrophonium. Now the answer is very clear, right? It's a simple, straightforward question. What is the answer? Right, obviously the answer should be option B, myasthenia gravis. Now answer me, why is it not Lambert-Eaton syndrome, why is it not botulism, and why is it not amyotrophic lateral sclerosis? First, why is it not amyotrophic lateral sclerosis? Amyotrophic lateral sclerosis is a motor neuron disease characterized by UMN plus LMN involvement, right? It is a motor neuron disease with, it's an MND, motor neuron disease, where there is UMN plus LMN involvement. Whatever information given here is not sufficient to diagnose a UMN plus LMN involvement. Second, in case of any other disorder other than neuromuscular junction, we don't see diurnal variation, right? So diurnal variation is a hallmark of neuromuscular junction disorders, right? It's a hallmark of neuromuscular junction disorders. Weakness more in the evening or more in the morning. Okay. Now botulism is a drug-induced neuromuscular dysfunction. You may have diurnal variation, but that will not show improvement with the administration of edrophonium, right? That is the point which goes against administration of edrophonium. And if it was Lambert-Eaton syndrome, then we all know Lambert-Eaton syndrome, the weakness will be more in the morning and less in the evening. Exactly opposite behavior of the myasthenia gravis. So that makes our diagnosis of myasthenia gravis almost certain on this question. Okay. Three Musketeers in Russia. Yes, absolutely right. Okay. Next question. So in this question, we have a 49-year-old man who was admitted to an emergency room with blood sugar level of 350 milligrams, and he looks dehydrated. The moment you say that blood glucose is more than 250 and patient looks dehydrated, what should come to your mind? Yes, we should start thinking about diabetic ketoacidosis. And as expected, this is also a case of diabetic ketoacidosis because ketones are detected in urine. So this is a classical case of diabetic ketoacidosis. Okay, now the rest of the question is pretty simple. Lab workup shows serum electrolytes revealing sodium of 130 milliequivalents and potassium of 3.8 milliequivalent. The patient is on insulin but has stopped using it due to personal issues. That is the most common reason for someone to develop diabetic ketoacidosis, right? The poor compliance with insulin is the most common reason for DKA. Now, what should be added to saline? That's the question. Right. So here it is a case of DKA, and DKA requires insulin infusion, right? Merely giving a subcutaneous insulin is not enough. The treatment of choice for diabetic ketoacidosis is insulin infusion. Okay. Ideally for this patient, we will also go on to require the addition of potassium chloride to the saline, because when we give insulin, what insulin does, it takes the potassium from your extracellular compartment or from your blood and puts it inside the cell. So the potassium levels will eventually drop down, and that is why we might need to also add potassium. But here we have to choose one best answer. The best answer would be to give insulin, right? That is the treatment of choice. Yes, Rahul Ranmale, that's the 0.1 unit micro unit per kg. So for a 50 kg person, we will start with 5 units per hour infusion. And then we have to titrate up or down according to the patient's blood glucose level. Okay. On examination of patient in medicine OPD, a patient was found to have raised JVP with a steep X and Y descent. Which of the following is the likely cause? Okay. First, rule out some unrelated options, and then we will come to the key point that we should learn from this question. Okay. Now, simple acute pericarditis don't do anything to JVP, right? Acute pericarditis, all that it will cause is, if there is an acute pericarditis, patient will have chest pain. We have discussed multiple times how to differentiate the chest pain of acute pericarditis from MI, right? The chest pain of acute pericarditis will have a relationship with respiration. It worsens on inspiration and improves on expiration. The chest pain of MI will not show such differences. The second thing is this will be associated with pericardial rub. Pericardial rub. Then the third point is that it shows ECG changes. What are the ECG changes of the acute pericarditis? The ECG changes of acute pericarditis are there will be ST elevation that will be concave. There will be PR depression, PR segment depression, and TP segment downsloping. Okay, so these are the ECG changes that you would expect in a case of the acute pericarditis. You will not see any abnormality of JVP until and unless the acute pericarditis has led to massive pericardial effusion causing the tamponade. A simple pericardial effusion also may not cause much of the JVP changes until and unless the volume is so much that it is constricting the heart. When it is constricting the heart, we call it as cardiac tamponade. If there is a effusion which is causing the compression on the heart, it is cardiac tamponade. So pericardial effusion in a simple case is unlikely to cause any changes on the JVP. So mainly we have to differentiate between cardiac tamponade and constrictive pericarditis. And to make you remember, I'll give you a simple mnemonic. No, thank you. No, thank you. No, thank you applies for cardiac tamponade. Okay. So in tamponade, there is no Y descent. In tamponade, there is T for tamponade. So in cardiac tamponade, there will be absent Y descent. There will be no Y descent. There will be a steep X descent, but there will be no Y descent. So now what is the option left with? Constrictive pericarditis, right? So that would be our answer. In constrictive pericarditis and restrictive cardiomyopathy, two conditions where you will have steep X and Y descent. Restrictive cardiomyopathy and constrictive pericarditis. In cardiac tamponade, there is a steep X descent but absent Y descent. There will be no Y descent, absent Y descent. This is also a repeatedly asked MCQ. Where do you get absent Y descent? Cardiac tamponade. No Y descent in tamponade. Simple. Okay. Next question. This is pretty straightforward question. Even a first MBBS student would answer that. Which of the following gene mutation is responsible for the following presentation in an adolescent with behavior issues and poor handwriting? What do we see here? What is this ring called as? Yes, so we have this ring-like structure here called as Fisher ring or KF ring, and KF ring is seen in patients with Wilson disease. And what is a gene mutation responsible for Wilson disease? Yes, it is ATP7B, right? There is also another gene, ATP7A. That mutation is responsible for which disease? ATP7A. ATP7A mutation. 7B causes Wilson, 7A causes Menkes-Kinckey hair disease, right? Or Menkes disease. Menkes disease or Menkes-Kinckey hair disease. Okay. Now, this is again a question which falls between surgery and medicine. In this question, we have a 30-year-old lady who presents with vomiting episodes and severe abdominal pain, which is referred to back. Okay, so an abdominal pain referred to back generally points towards the pain originating from the gastrium or stomach or the pancreas. Okay, now the following examination findings were noted. Comment on the diagnosis below. Okay, so what do you see here? We can see bruising, right? Bruising in the periumbilical area. Around the umbilicus, there is bruising. So what is this called as? This sign is called as Cullen's sign, right? This is called as Cullen's sign. Cullen's sign is seen in which condition? Right, it is seen in acute pancreatitis. So if there is a bruising on the flanks, what do we call it as? If there is a bruising on the flanks, we call it as Gray-Turner's sign. Gray-Turner sign. So around the umbilicus is Cullen's sign. In the flanks, it's called Gray-Turner sign. Both are findings of acute pancreatitis, right? It is pretty easy to remember. You can make a C around the umbilicus. So C for Cullen's sign. And when you turn, right, you turn to like constrict your flank region. So turn for Turner sign, C for Cullen sign around the umbilicus. Okay. Now again a very simple physiology anatomy based question. All of you know the answer. Corticospinal tract crosses over at which level? Now we have studied this localization in neurology in sufficient detail through various sessions, so you should be able to answer this question. Corticospinal tract crosses over at which level? See, corticospinal tract originates in the motor cortex, descends down through subcortex internal capsule, comes to the brainstem, right? But in the spinal cord, it is already crossed. So where does it cross? Right, it crosses at the lower medulla. That is the answer. Simple, straightforward. No need to know anything more than that, right? Corticospinal tract crosses at the lower end of the medulla. Okay. Now one question. Which drug is used in emergency management of asthma but does not cause bronchodilation? We do use it in emergency management of asthma, but it is not a bronchodilator. Okay. Salbutamol. Yes, obviously we use it. It is the go-to drug when it comes to bronchodilation. Is it a bronchodilator? Yes, it is the main bronchodilator used in asthma. It's a bronchodilator. Okay. Ipratropium. What is it? Ipratropium. What is it? Ipratropium is it a long-acting antimuscarinic agent or a short-acting antimuscarinic agent? Yes, answer is right. All of you are right. It is hydrocortisone. Yes, we use it in acute asthma, but it is not a bronchodilator. It's an anti-inflammatory agent. That's why we use it. Okay. Ipratropium is a SAMA, short-acting antimuscarinic agent. There is one more agent called as tiotropium. Tiotropium is a LAMA, long-acting antimuscarinic agent. Why this is important? Because in an acute case, here we are talking about emergency. If I had given tiotropium here, then that would have been also an answer. Because tiotropium is long acting, we don't use long acting agents in acute emergencies. We want quick acting, short acting agents in emergencies. Right? Easy to remember in the alphabetical order, because I comes first, you can relate it to short acting. T comes quite late, so you can relate it to long acting. Okay. Now what is the mechanism of action of deriphyllin? We no longer use it. It was used once upon a time in acute asthma conditions. What is the mechanism of action? The mechanism of action is, it is the phosphodiesterase inhibitor. It is a phosphodiesterase inhibitor. Okay. Now, next question. Here we have a 45-year-old woman presents with irritability and drowsiness for last 3 weeks. Duration is important. Pay attention to all questions about the central nervous system dysfunction. Whenever they talk about it, pay attention to the duration. She complains of headache on being awakened and wants to sleep. So she is irritable, drowsy, and she has headache. Physical examination reveals decreased GCS and neck rigidity. Right? Now at this point of time, what is your diagnosis? With this much information, irritability, drowsiness, neck rigidity and headache. We are all thinking of meningitis. We're all thinking of meningitis. Okay. The next question. In case of meningitis, what would be the investigation of choice? It is lumbar puncture for CSF analysis. So as expected, they have done this CSF analysis. And CSF shows 100 lymphocytes, glucose 54 milligrams per deciliter and protein 3 gram percentage. What would be the next best management for this patient? So now to decide whether I should give antibiotics or whether I should give anti-tubercular drugs, antivirals or antifungals, I need to know what kind of meningitis it is from the LP. So what do you think? Is it tubercular meningitis or it is bacterial meningitis, viral or fungal? I think all of us do agree that this is not bacterial meningitis, right? Why is it not bacterial meningitis? This is not bacterial meningitis because in bacterial meningitis, there will be neutrophil predominance, right? Neutrophil predominance. So that's why it is not bacterial, right? But why is it not viral? I got it, right? It is not bacterial because in bacterial, like more than 80% of the cells will be neutrophils only. Why is it not viral? In viral also you will have lymphocyte predominance. Yes. So there are two factors which go against viral. Why is it not viral? It is not viral because of two reasons. Number one, the glucose is low, right? The blood glucose, the CSF glucose level is relatively low. More important than that, because see here, this question is little flawed. I cannot give much emphasis to the glucose level because CSF glucose level is always a derivative of the plasma glucose level. CSF glucose is equal to, right, is equal to 2/3 of plasma glucose. Because here they have not told how much is the plasma glucose, I cannot give too much importance to that value, but I can still confidently say that this is not a viral meningitis. Why? Because, yeah, 60% or 2/3, right, absolutely right. Viral meningitis is always an acute presentation. It won't last for 3 weeks, right? So here it is the subacute presentation. It won't last. It can't be viral because of its subacute presentation. Viral meningitis and bacterial meningitis is all acute presentation. By the end of 3rd week, either patient has recovered or is dead. There is no continuation of the disease by 3 weeks. If it is bacterial or viral, they are acute meningitis. So only differential diagnosis here would be tubercular meningitis and fungal meningitis, right? So here it's not viral because this case is glucose is low and it is subacute presentation, not acute presentation. Because of these 2 reasons, it is not viral. Okay. Now, why is it not fungal? Fungal also will have lymphocyte predominance, right? It is not fungal because, see, remember now, fungal most commonly occurs in individuals who are immunocompromised. This patient is not immunocompromised. Patient not diabetic or not immunocompromised. They have not told anything suggestive of immunocompromise. So generally we wouldn't think of fungal meningitis in the absence of immunocompromise, right? HIV, diabetes, cancer, chemotherapy, nothing is there. So keeping these points in mind, we would come to the diagnosis of TBM, right? So this case is a case of tubercular meningitis and starting ATT is the most logical step, making that as our answer of choice. So please remember, you may not get all the information you need to make a diagnosis of viral, bacterial, fungal or tubercular from the CSF. So you have to take help of history, right? The duration, if it is subacute or chronic, only then think of fungal or tubercular. If it is acute, think of bacterial or viral. Okay, clear. Now next question. Which of the following condition will lead to development of wing beating tremor? Wing beating tremor. So if you have seen our recorded video lectures or the offline classes, then you have already seen a patient with this tremor, right? So in which condition we see that? Right. We see that in Wilson disease, right? That's a classical example for wing beating tremor. You might have seen that patient video where when we try to approximate his hands at the eye level, he will start moving his hands up and down like the beating of the bird's wings. That's what we call as wing beating tremor, right? So that's a classical tremor of Wilson disease. Okay, next. A female patient, see, please pay attention to gender, female malar rash fever, right? And she has been found to have vegetations on the either side of the heart walls. What can be the diagnosis? So first thing is, forget about the heart diagnosis. What is the overall diagnosis in this case? A female malar rash and fever. What is the diagnosis? Female malar rash and fever. Right. So this is a case of SLE, right? Now, what are the cardiovascular manifestations of SLE? Cardiovascular manifestations of SLE. What is the most common cardiovascular manifestation of SLE? That is an MCQ. So the most common cardiovascular manifestation of SLE is, anybody giving me the answer? Yes, all of your answer is right, but there are a few more points to learn about SLE and heart. The most common cardiovascular manifestation of SLE is not endocarditis. So all rheumatological disorder, please remember now, whether it is rheumatoid arthritis, Sjogren's syndrome, or the systemic sclerosis, the scleroderma, or SLE, in all cases, the most common cardiovascular manifestation would be pericarditis. Similarly, the most common respiratory manifestation would be pleuritis, right? So be it rheumatoid arthritis, be it SLE, Sjogren's, or any of the rheumatological disorder, most cases with your closed eyes, choose membrane inflammation as the most common manifestation. So most common is pericarditis. Pericarditis is the most common cardiovascular manifestation. Okay. Apart from that, please remember SLE affects all the three layers of the heart. So SLE can also cause myocarditis. SLE can also cause endocarditis, and SLE can also affect coronaries. So there is increased risk of coronary artery disease. Okay. Now the endocarditis here, it's not because of the bacterial infection. So we call it as sterile endocarditis. Sterile because there is no bacterial infection. And that sterile endocarditis is also recognized with the name of Liebman-Sachs, right? Liebman-Sachs endocarditis. So here this patient has got vegetations on the valves, indicates that he has got the Liebman-Sachs endocarditis. So this is a case of SLE with Liebman-Sachs endocarditis. Okay. Now why is it not rheumatic heart disease? For the diagnosis of rheumatic heart disease, there are two things. Rheumatic fever is different from rheumatic heart disease, right? Repeated episodes of rheumatic fever lead to permanent damage to heart valves, then we call it as rheumatic heart disease. So to call it as rheumatic heart disease, I need the evidence of valve stenotic lesions, right? Mitral stenosis. Most common valve involved in rheumatic heart disease is mitral valve, and most common manifestation would be mitral stenosis. So in this case, there is no mitral stenosis. So I cannot consider it as the rheumatic heart disease, right? Why is it not infective endocarditis? To diagnose infective endocarditis, we need to meet all the criteria listed for infective endocarditis. Merely this information is not sufficient. And in SLE patient, first thing is the diagnosis of Liebman-Sachs endocarditis. Only when your blood culture is positive for bacteria, I would think of the infective endocarditis, right? So here they are not mentioning about any blood culture being positive for the bacteria to think of infective endocarditis. Okay. Next, patient has been admitted to ICU since he is having fever, right? So primary complaint is fever for 4 days. So it is a short duration fever with new onset breathlessness. So breathlessness started now, right? And it is unresponsive to incremental flow rate of oxygen. So he is requiring more and more oxygen and still he remains hypoxic. The saturation is progressively decreasing. What can be the diagnosis? Right. So let us look at individual options. Can it be mediastinitis? What is mediastinitis? Inflammation of the structures in the mediastinum. So that includes heart and other structures, right? So the mediastinitis usually presents with myocarditis because heart is there in the mediastinum, and myocarditis would have this characteristic ECG changes. It might present with acute heart failure. Acute heart failure. Now in this question, right, whatever information I have, that won't suggest acute heart failure. Patient doesn't have bilateral basal crepitations, right, raised JVP or X-ray showing flow rate pulmonary edema. Those information is not there. So I wouldn't suspect an acute or a sudden onset heart failure or a myocarditis in this case. Okay. Then can it be idiopathic pulmonary fibrosis? Idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis or IPF is the most common interstitial lung disease, right? It is the most common interstitial lung disease, which is common in elderly, and it is a chronic condition. So in this case, the complaints are related to very short duration. It is a chronic ILD. Because it is chronic ILD, it can't be the answer, right? Now atelectasis, collapse of the lungs. That is a possibility, but if only a portion of the lung is collapsed, then remaining portion of the lung is working. So if you give more oxygen, their oxygen levels would be maintained. They would not require increasing doses of oxygen. So that's why it is unlikely to be atelectasis. So we are left with option C, ARDS as the answer, right? So ARDS would be the answer. In fact, any patient in ICU, if they develop rapid onset shortness of breath, the first thing that should come to the mind of the ICU doctor is ARDS. Now before I move further, right, what is the diagnostic criteria for ARDS? Because that can be an MCQ, right? Diagnostic criteria for ARDS. The diagnostic criteria for ARDS is called as, named after a city. Which city? That's called as Berlin criteria, right? So please remember the Berlin criteria, spend some time on it for revision, and please remember the severity classification of ARDS based on the PaO2 by FiO2 ratio. Okay. Next question. What is the best treatment for empyema? Right? What is empyema? Empyema means pus in the pleural cavity. Right? empyema, pus in pleural cavity. So what would be the treatment? Can I simply put a needle and draw the pus and treat the patient with antibiotics? No, because your pleura is infected, there is a battle happening between your immune system and the bacteria. There will be a lot more pus generated subsequently. So till bacteria are destroyed, pus will keep on forming. So merely putting one needle will solve the problem for today, but tomorrow again pus will accumulate, right? So the ideal treatment for any patient with empyema would be to put an intercostal tube drainage so that whatever pus formed will keep draining, and to kill the bacteria which is responsible for the infection we need to give antibiotics. So option C would be the right answer. Okay. Next question. A worker working in wheat facility, right? So he is working in a factory which works on wheat. Okay. Presents with yellowish discoloration of the eyes, pruritus and weight loss. 6 kg weight loss over 3 months. Is it a significant weight loss? Is it a significant weight loss? Yes, it is significant, right? So when do you call it a significant weight loss? The weight loss is considered as significant if it is unintentional and the loss amounts to more than or equal to 10% of body weight within 6 months. Within 6 months, or more than 5% of body weight within 3 months. So for this 6 kg would be a significant weight loss for an average sized adult, right? If anybody has lost 6 kg within 3 months unintentionally, it is a significant weight loss. General physical examination showed jaundice and abdominal examination revealed hepatomegaly with ascites. Based on investigation, he has been diagnosed with a case of hepatocellular carcinoma. So which toxin is associated with hepatocellular carcinoma? Right, we all know it is aflatoxin. Aflatoxin is associated with the risk of hepatocellular carcinoma, and that's why option B would be the answer. Okay. Can anybody tell me where do you see this tetrodotoxin? In forensic medicine, you study most other toxins. So where do you see this tetrodotoxin? Tetrodotoxin is usually seen in a fish called as Ciguatera fish poisoning. So if you eat this fish, that carries tetrodotoxin and that upsets your GI as well as your central nervous system. Okay, in which of the shock CVP will be raised? What is CVP? CVP stands for central venous pressure. Central venous pressure. So basically it is a pressure measurement of your superior vena cava. It indirectly represents your right atrial pressure. So this is a measurement of JVP. JVP is visualized or traced in waveform. If you put a line into the superior vena cava and check the JVP, that itself is central venous pressure. In which type of shock CVP will be raised? Okay, so what makes you think distributive shock the CVP will be raised? What is distributive shock? See, in distributive shock there is peripheral vasodilatation. Give me one example where you see distributive shock. Peripheral vasodilatation. Where do you see distributive shock? Why is it called distributive shock? The circulating blood is all distributed to peripheral tissues. It is all there in your palms, soles, feet and peripheral tissues, and less blood in your central circulation. Less blood in your central circulation. A classical example for a distributive shock is sepsis. Sepsis is a classical example. So in sepsis, because of the inflammatory cytokines, peripheral vasodilatation happens. So all the blood from your central circulation, your main blood vessels and main veins, goes into your peripheral tissues. So centrally circulating blood volume is less. So if the centrally circulating blood volume is less blood volume is coming to right atrium. So right atrial pressure will be low. So in that case JVP will be low. So in that case CVP will be low, right? So it is not the distributive shock. Okay. Hypovolemic shock, same as distributive, right? Means in the sense here also central circulating blood volume is less because your volume as such is low. So right atrial pressure will be low, CVP will be low, right? So septic shock is nothing but a type of distributive shock. So what should be the answer? Cardiogenic shock. So in cardiogenic shock, heart is not able to pump, right? When heart is not able to pump, when right ventricle, left ventricle don't pump well, what will happen to the transfer of blood from right atrium to right ventricle? and left atrium to left ventricle. So if right ventricle doesn't pump out well, the blood stays back in the right ventricle. So pressure gradient between right atrium, right ventricle is very minimal. So most of the pressure will be borne by the right atrium. So the right atrial pressure will increase. If right atrial pressure will increase, CVP will increase, right? So in all other cases of shock, the CVP will be low. But in case of cardiogenic shock, the CVP will be high. Right 3 years. In cardiogenic shock, the CVP will be high. All other cases, CVP will be low. So that is pretty easy to recognize cardiogenic shock. If you put a CVP and it shows high but patient blood pressure is very low, then you have cardiogenic shock. You have put the CVP is very low, patient blood pressure is very low, then it is not cardiogenic shock. It could be the other forms of shock. Simple, right? Okay. Again, a very straightforward question. A 30-year-old female came with complaints of lethargy, gained over 9 kgs of weight in past 3 months, has dry skin, hair loss, intolerance to cold and constipation. What is the diagnosis? Pretty straightforward, right? Yes, it is a classical case of hypothyroidism. The opposite of that would have happened if it was a case of hyperthyroidism. She would have lost weight, she would have heat intolerance, right? And she would have sweaty skin. Hair loss would happen whether hypo or hyper. Okay. Now the next question. Patient presents with dyskinesia, rigidity and problem in substantia nigra. Which neurotransmitter is involved in this condition? Simple, right? All of you know the answer. Rigidity, dyskinesia, right? So this question is primarily talking about Parkinson's disease, right? The question is about Parkinson's disease. And in Parkinson's disease, the problem is in substantia nigra and the neurotransmitter in substantia nigra is dopamine. So answer A would be the correct answer. Okay, next question. Patient presents with fatigue, restlessness, and on investigation he is found to have macrocytic anemia. Serum methylcobalamin level is normal. Which of the following should be given to the patient? So in day-to-day practice, if you see macrocytic anemia, right, it is most likely because of two causes. There are other causes also, but overall 90% of the cases, either it is because of B12 deficiency or folic acid deficiency. These are the most common causes. Now when they say that the cobalamin level is normal, B12 deficiency is ruled out, so we are left with folic acid deficiency, and that is what we should be administering in this case. Okay, can anybody tell me drugs causing macrocytic anemia? Drugs causing macrocytic anemia. The most common set of drugs which cause macrocytic anemia in today's practice, yes, methotrexate is one. Yes, very important. Then, yes, there are a lot of anti-epileptics, and your heart treatment means highly active antiretroviral therapy. Drugs causing macrocytic anemia. Yes, methotrexate. Okay. And then highly active antiretroviral therapy. Among them, right, zidovudine is the most common drug. Nowadays, we don't use zidovudine in the current regimens, but there are some patients who have been following zidovudine from the past. They are also continuing zidovudine. They may present. Yes, metformin. Metformin causes B12 deficiency, and that's how it causes the macrocytic anemia. Now, back in the days when I was studying, we used to assess whether patient is taking the zidovudine or not by looking at whether he is anemic or not. If he is not anemic, it means he is not taking the zidovudine. Okay, which of the following has worse prognosis in the options given below? Pulselessness, paralysis, paresthesia, pallor. Obviously, not having the pulse would mean that you should start CPR, and that would carry the worst prognosis, right? It's not a brainer anyway. Okay. A 65-year-old lady presents with problems with balance while standing. On neurological examination, she is found to have loss of vibration and proprioception. Which of the following should be administered? What do you think should be the answer here? 65-year-old presents with problems in balance. Right, so what is the diagnosis? What is the diagnosis? Answer is correct. What is the diagnosis? Right, so here The patient has got something called as SACD, subacute combined degeneration. Subacute combined degeneration. So mainly the degeneration affecting the dorsal column, right? So there is degeneration of dorsal column. Dorsal column carries the vibration and proprioception. Second, patient also probably has the peripheral neuropathy. So both combined together is not able to maintain the balance, and subacute combined degeneration happens because of the severe deficiency of vitamin B12. So this patient would require administration of vitamin B12. Okay. Now here we have a 70-year-old patient presents with sudden onset chest pain. ECG is in front of you, so you have to localize which MI it is. It cannot be reversed, but B12 administration is absolutely crucial because there are plenty more complications on the way for the patient who already has severe B12 deficiency. It is degeneration, degenerated neurons. We will not be able to regenerate them. Okay, so which MI it is? So when I see the ECG closely, I will notice that there is ST elevation in lead 2, 3 and AVF, right? So we can see the ST segment is elevated in 2, 3 AVF, and I'm not very sure about the lead 1, though I can see a bit of ST depression, but I'm convinced that there is ST depression in AVL. So ST depression in AVL, ST elevation in 2, 3 AVF, and ST depression in 1 doubtful, but AVL I am very sure. So what is this? This is a classical case of inferior wall MI, right? Inferior wall MI. Okay, so please remember that for 2, 3 AVF, lead 1 and AVL act as reciprocal lead. So if there is ST elevation in 2, 3 AVF, 1 and AVL should show ST depression if it is a case of STEMI, and we see that, so that's why it's a case of classical case of STEMI, and it is inferior wall MI. Now they might also ask you a question, which blood vessel may be most likely occluded in this patient if we do a angiogram. So what should be your answer? What is the predominant blood supply to the inferior wall? The predominant blood supply to the inferior wall is RCA. 80% of the blood comes from RCA, right? So that's why if they ask you blood vessel involved for inferior wall, the most commonly involved blood vessel will be RCA, right? For anterior wall, the most commonly involved blood vessel will be LAD. Okay. Now why is it not pericarditis and why is it not posterior wall MI? In pericarditis, ST elevation affects multiple leads, but it will also be accompanied by, why is it not pericarditis? It's not pericarditis because it is not affecting multiple leads, it is only affecting one anatomical region, right? Not affecting multiple leads. And the second, what other ECG findings we will see? We will also notice that there should be PR segment depression and a downsloping TP segment. All that is not seen in this ECG. There is no downsloping TP segment, there is no PR segment depression. See, when you look at the PR segment, okay, the ECG is not very clear, but PR segment appears to be on the baseline. This is PR segment, this is baseline. Both are at the same level. So that makes it unlikely to be a case of the acute pericarditis. Then why is it not posterior wall MI? We cannot diagnose posterior wall MI on a standard 12 lead ECG. We need additional leads to be placed for the posterior wall to recognize posterior wall MI. Second, in case of posterior wall MI, the anterior leads will show ST depression, which is also not seen, right? So our answer is firm, that is option B, inferior wall MI. Okay. A young patient developed sudden onset fever and agitated behavior for 2 days. No meningeal signs were noted. CSF shows 40 cells and 90% lymphocytes and 10% neutrophils with elevated protein. Which of the following should be started in this patient? What do you want to start in this patient? What is the diagnosis? Okay, how many of you think we should start ATT on this patient? And those who don't want to start ATT, why not ATT? Okay, few points here. Number one, it is a sudden onset fever and agitated behavior, right? Okay, now in a normal meningitis, simple uncomplicated meningitis case, do we see behavioral changes? Behavioral changes in a case of meningitis, generally unexpected. We don't see behavioral changes in a patient with meningitis. Okay, that is one point. Second, why I don't want to start ATT? Because it is a sudden onset fever, right? It's an acute presentation. So it can't be fungal or the tubercular meningitis. So whatever, if you are thinking of meningitis, I have to think of mainly viral or bacterial. Now, why is it not bacterial? Because I see lymphocyte predominance, right? So it is most likely viral if you want to take it as meningitis. But meningitis alone will not explain his agitated behavior. Second, there are no meningeal signs present. So meningitis becomes bit less likely. So what it could be? It is most likely encephalitis. Encephalitis. What is encephalitis? Meningitis is inflammation and infection of meninges. Encephalitis is inflammation and infection of brain parenchyma. Because brain parenchyma is involved here, patient probably has the behavioral changes. Okay. So obviously encephalitis is most commonly caused by herpes simplex virus, and we can treat them with the antiviral. So 𝐒𝐂𝐈𝐀 would be the drug of choice. Even if you have misconfused it as the viral meningitis, still fine. The treatment would still be 𝐒𝐂𝐈𝐀. And in practice also, this is what happens. Many times viral meningitis and viral encephalitis are interchangeably diagnosed, but because treatment doesn't differ, there's no problem, right? So encephalitis, most common cause, yes, it is herpes simplex virus 2 or HSV2. Yeah, all the questions are derived from the previous year's questions itself. So I'm not trying to bring in anything new because it's not the time for us to discuss anything new. Okay, next question. Best treatment for unconscious middle-aged patient in the ambulance shall be which of the following? This is a ambulance ECG rhythm strip. Best treatment for unconscious middle-aged patient in ambulance, which are the following? This is the ECG, right? First, tell me what is the ECG diagnosis. Okay, see, how do we approach ECG with the abnormal rhythm? Okay, let me ask one basic question. Is it a tachycardia or bradycardia? Tachycardia or bradycardia? When you look at RR interval, right, clearly it is less than 1. So heart rate must be more than 300. So this is a condition with tachycardia. Okay. Now in a tachycardia case, is it a wide complex tachycardia or narrow complex tachycardia? Yes, it is tachycardia. All of us agree that there is tachycardia. Wide QRS complexes or narrow QRS complexes? What is the normal QRS duration? Normal QRS duration should be less than 3 small squares, right? Here, is it less than 3 or more than 3? This is one QRS complex, right? This is one more QRS complex. So is it less than 3 small squares or more than 3? It is more than 3 complexes, right? It's almost like 4. It's almost like 4. So when it is more than 3, it is a wide complex tachycardia. Wide complex tachycardia, right? Now, what are the causes for wide complex tachycardia? Ventricular tachycardia, ventricular fibrillation. There is also one more entity called as SVT with aberrancy at FMGE level. Never ever think about it. So we have to mainly differentiate between VT and VF, right? Okay. As you know, VT has two types, the monomorphic VT and polymorphic VT. Monomorphic and polymorphic. In monomorphic, in one lead, all the ECG QRS complexes look same. In polymorphic, they look different. Okay. Then in VF, also all the QRS complexes are wide, but they also look different. So the question would be how to differentiate between a polymorphic VT and a VF. The main difference is that in VF, the amplitude of the QRS complexes will be less, and there will be more than 50% variation in the amplitude. The small complex and the large complex amplitude variation will be very high, and they will be like the voltage of the QRS complexes will be less. So when I look at this ECG, right, do they look like normal sized QRS complexes or small? Do they look like normal size QRS complexes or small? To me, they relatively look like smaller than the normal size QRS complexes. The normal size QRS complex would have looked somewhat like this, right? So there are small, voltage of the QRS complex is less. And when you look at the variation in the voltage, right? Look at the voltage here and look at the voltage here. There is certainly more than 50% increase, right? From here to here, like definitely more than 50% jump. So this is a classic case of ventricular fibrillation. So this ECG is suggestive of VF, right? VF will almost always be pulseless. Almost always be pulseless, because in ventricular fibrillation, ventricle is merely shaking, not contracting. If it doesn't contract, who will push the blood into the aorta? Nobody, right? So in that case, what should I do? Like, should I wait for patient to be shifted to ICU, or should I do carotid massage, or just observe or start CPR and defibrillation? Okay, so see, in case of the ventricular flutter, see, ventricular flutter is an extremely rare condition. Second, as long as you are meeting the ECG diagnostic requirement of VF, VT, VF are your two major differential diagnoses for wide complex tachycardia. If you are thinking of atrial flutter, right, what you are seeing is not the sawtooth pattern. See, in case of atrial flutter, if it is atrial flutter that you are thinking of, in atrial flutter, you will have multiple P waves and few QRS complexes. Multiple P waves and few QRS complexes. So I don't see few QRS complex and multiple P waves here, right? So I see only QRS complex and I don't see any P waves. So in any patient who is unresponsive and has a ventricular fibrillation, you have to start CPR. If it was a case of VT, I change the ECG, same story, but ECG is VT. Then how will you do? What will be your answer? If I change the ECG, same story, unconscious patient, middle age, is in the ambulance, ECG is changed to VT. Will you start CPR and go for defibrillation or administer some drugs? See, if it is VT, we decide based on whether it is pulseless or with pulse, right? If it is pulseless VT, then we treat it same like ventricular fibrillation. Any patient with no pulse CPR, standard, right? On the other hand, if it was VT with pulse, then we look at the blood pressure. Blood pressure more than 90/60, we give them the drug. What is the drug of choice? Currently, amiodarone is considered as the drug of choice. Amiodarone is considered as a drug of choice. But if the BP is less than 90/60, then we go ahead with the defibrillation. There is no role of CPR as long as patient has pulse, right? Okay, so here it is VF. So VF will almost always be pulseless and we have to start the CPR, and that patient would require CPR. Okay, next patient. CLD patient presented to OPD with fever and gross abdominal distension. On abdominal examination, there is tenderness present. Ascitic fluid reveals presence of 500 cells per cubic millimeter. What is the next best step? So, right, what is the diagnosis here? It's a case of CLD. CLD presenting with fever and abdominal pain. What should come to your mind? You should start thinking about the spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis. Okay. Now the ascitic fluid report, is it conclusive of spontaneous bacterial peritonitis? Right. So if the ascitic fluid shows more than 250 neutrophils or polymorphonuclear cells per cubic millimeter, it is diagnostic of spontaneous bacterial peritonitis. So keeping that in mind, we will take it as spontaneous bacterial peritonitis, and obviously that patient needs antibiotics, right? So currently third generation, the drug of choice are third generation cephalosporins. Cephalosporin. So option D becomes the correct answer. Okay. Now among the options provided, right, in which condition you would use octreotide? In a CLD patient, when do you use octreotide? Right, correct answer would be ceftriaxone. In a CLD patient, when would you think of using octreotide? So in a CLD patient, octreotide is used if patient has got esophageal variceal bleed. Variceal bleed. But there also the drug of choice for esophageal variceal bleed is no longer octreotide. What is the drug of choice? That is not drug of choice. Drug of choice would be terlipressin, right? Terlipressin. Yes, right. So octreotide can be used in acromegaly. Now, why do we use it in acromegaly? Because octreotide is a somatostatin receptor blocker or somatostatin analog. Somatostatin analog. Yes. Why are we using terlipressin in case of the esophageal variceal bleed? Why terlipressin? What is terlipressin? Terlipressin is a vasopressin derivative, right? Vasopressin does three important functions. First one, the most important function of vasopressin is what? It acts on the kidney to regulate the water level, right? And indirectly it regulates the osmolality. Second, it stimulates the anterior pituitary gland to release ACTH. Third, it does is it causes vasoconstriction. That is why when BP is low, we use vasopressin. It causes vasoconstriction. The advantage of terlipressin is terlipressin selectively causes vasoconstriction in the splanchnic circulation. So the esophageal varices, the blood vessels will get constricted and the bleeding would stop. Because it is selective vasoconstrictor of the splanchnic circulation, it becomes the preferred choice. Now if I give octreotide, right, it will antagonize, it will act as a somatostatin analog. It can also cause some bit of vasoconstriction, but it will also affect other hormonal profile and it is not as effective as terlipressin, so it is not used. Okay. Now in what situation you will use large volume paracentesis in a patient with CLD? What is LVP? Mainly ascitic fluid tap, taking out large quantity of fluid. When is it indicated? When is it indicated? When the ascitic fluid accumulation is leading to shortness of breath. To relieve the shortness of breath, we release the fluid. Okay. And whenever we do large volume paracentesis, it should always be accompanied by albumin. If you don't give albumin, what is the complication you can anticipate? Not giving albumin during large volume paracentesis increases the risk of hepatorenal syndrome and increases the risk of hepatic encephalopathy. Right? Okay. Now the next question, a 65-year-old man presents with excessive cold intolerance, hypertension and slow ankle jerks. He is also having hypertension. The thyroid function test shows TSH of 16 and low T3, T4. What is the appropriate management? Now before going to management, question, what is the diagnosis here? T3, T4 are low, so we know it is hypothyroidism, right? But the question is whether it is primary hypothyroidism or secondary or tertiary. Primary, secondary or tertiary. Primary, secondary or tertiary. Okay, see, normally what happens, we have a hypothalamus, then a pituitary gland, right? So from the hypothalamus, we get the TRH, thyrotropin releasing hormone, which stimulates the pituitary gland to produce another hormone, that is TSH. And this TSH will act on the thyroid glands to produce T3 and T4. In endocrinology, this term, when you say that primary, like when you say primary hypoadrenalism, primary hypothyroidism, primary anything, it relates to the gland itself. So if the gland itself produces less quantity of hormone, the problem is in the gland, then it will be called as primary. If the problem is in the next level management, that is pituitary gland, it will be called as secondary. If the problem is in the next level management, that is hypothalamus, it will be called as tertiary, right? So primary means the problem is in the gland. So if the problem is in the gland, it is called as primary. If it is in the pituitary gland, it is secondary. If it is in the hypothalamus, it will be called as tertiary. Now, how would I get to know whether it is primary, secondary or tertiary? Because many times the question story will clearly tell you that this is hypothyroidism or hyper, and then they will ask you whether it is primary, secondary or tertiary. How to answer that question? See, normally, now think about it. If the gland is not producing sufficient quantity of T3 and T4, in a physiological state, what should happen to TSH? TSH should rise, right? So if gland is not producing sufficient T3, T4, TSH will rise. What will happen to TRH? That will also rise, right? That is a classical story of primary hypothyroidism, right? So if it is primary hypothyroidism, the problem is in the gland, problem in thyroid gland. So thyroid gland will not be able to produce sufficient T3, T4. So the T3, T4 will be low, right? And to compensate for that, pituitary gland will start producing more TSH and your hypothalamus will start producing more TRH. So this will be a classical picture of primary hypothyroidism. Now if it is secondary hypothyroidism, the problem is in pituitary gland. Problem in pituitary. So pituitary does not produce sufficient TSH. TSH is low because sufficient TSH is not coming to the gland is not producing sufficient T3, T4. So T3, T4 will be low, TSH will be low, but the TRH will be high because there is no problem with the hypothalamus here. If it is a case of tertiary hypothyroidism, then the problem is in the hypothalamus. So in that case, everything will be low because your hypothalamus is not producing sufficient TRH, pituitary is not producing sufficient TSH, and because pituitary is not producing sufficient TSH, your thyroid gland is not producing sufficient T3, T4. So if all three are low, then it is tertiary. Okay. If both the T3, T4 and TSH are low and TRH is high, then it is secondary. In primary, T3, T4 will be low, TSH and TRH will be high, right? Now looking at this profile, what do you think? This is primary, secondary or tertiary? Please remember one point, tertiary is extremely rare. So until and unless they ask you to identify tertiary, you don't need to think about it. You have to mainly differentiate between primary, secondary. So if I have to choose primary or secondary here, what would be your answer? T3, T4 low, right? The normal range of TSH is less than 5, right? 1 to 5 or less than 5. Here it is 16. So TSH is high. TSH high, T3, T4 low. So what would be the answer? Yes, this is primary hypothyroidism. This is a classical case of primary hypothyroidism. One last question. What is the most common cause for primary hypothyroidism? Right, let us document this point also. Most common cause for primary hypothyroidism. Is it iodine deficiency or something else? It used to be iodine deficiency once upon a time in the past, but it is no longer a concern, right? So currently the most common cause for primary hypothyroidism is autoimmune disease or Hashimoto's thyroiditis. So until and unless the question specifically asks you what is the most common cause for primary hypothyroidism in iodine deficient world or the hilly regions, only then mention iodine. In the common world, it is not iodine anymore. It is the Hashimoto's thyroiditis. Okay. So now this is a case of primary hypothyroidism. Now if you diagnose a case as primary hypothyroidism, how do you treat? We give them thyroid hormone replacement, right? Thyroid hormone replacement in the form of levothyroxine, and the dose would be levothyroxine. The dose would be 1.6, right, micrograms per kg per day, right, per kg per day. That will be the starting dose. According to control, we can increase or decrease the dose, but the starting dose will be 1.6 micrograms per kg per day. But please remember, in elderly, right, we start low. Like we start with 12.5 to 25 microgram per day, irrespective of their weight, and then adjust the dose. Why do we do that? Because of the poor tolerance. They are at increased risk of, because of poor tolerance, they are at increased risk of developing atrial fibrillation. Poor tolerance and AFib risk. elderly don't tolerate suddenly giving them a normal dose of thyroid hormone. So we start very low. You can give them, nobody is stopping you from giving them 100 microgram, 125 or 150, but you have to start low, slowly build it up, right? Okay, so now going back to the question, what do you think should be the answer? What do you think should be the answer? Which option should be the answer here? Right, it would be option A, because here it is an elderly patient, right? If I change the age to 35, right, a 35-year-old female, that's a classical case of Hashimoto's thyroiditis, then it will be 1.6 micrograms per kg. If I mention that it is a 50 kg person, then 1.6 into 50 will be like 75 to 80 something. That is the dose that I would start. If I mention that it is a 70 kg person, then 1.6 into 70 will be like 110 or something. That is the dose I would start. But here it is an elderly man and we have to start at low dose and increase gradually. Gradually come back to the dose that you would require. So option A would be the correct answer here. Okay. Next question. A patient is having sudden exacerbation of dyspnea and he can't talk. Means he's so short of breath that he can't talk. On chest auscultation, prolonged expiration is noted. ABG shows a pH of 7.3, PCO2 of 84 and bicarb of 33. Which of the following intervention should be done? Right. Now what is the ABG diagnosis? ABG. pH is less than 7.35, right? So that means it is acidosis. Now which type of acidosis it is? Metabolic or respiratory? PCO2 is increased, pH is decreased. Both are in the opposite direction. So it is respiratory acidosis, right? Respiratory acidosis is generally due to hypoventilation. The most common cause for respiratory acidosis is, it is usually due to hypoventilation, sufficient ventilation of the lungs not happening, right? And the most common cause for respiratory acidosis is COPD. Now what is the solution for this patient's problem now? Will fluid restriction help? No, fluid restriction would be useful for a patient with heart failure or a renal failure or CLD. It is of no use here, right? Should we give him sodium bicarbonate? Sodium bicarbonate may be useful for a patient with metabolic acidosis. Where there is bicarbonate shortage, you are giving the bicarbonate, right? That would be used for metabolic acidosis, not for the respiratory acidosis. Fluid restriction is for heart failure, CLD, CKD, not for the organ failure, right? Ammonium chloride administration doesn't serve the purpose, right? So here you have to improve the ventilation. Hypoventilation is the reason. Improve the ventilation. We start with the non-invasive ventilation, right? So NIV with a positive airway pressure, that would be the initial treatment of choice. Preferably we use BiPAP. Bi-level positive airway pressure would be the treatment of choice when it comes to COPD leading to type 2 respiratory failure and respiratory acidosis. Okay. Now one last question. Where do you use the CPAP? BiPAP is, there is a small spelling mistake. It should be NIV PAP or NIV BiPAP. Okay. Where do you use CPAP? CPAP is the treatment of choice for which condition? Continuous positive airway pressure. Treatment of choice for, that is a treatment of choice for obstructive sleep apnea or OSA. Obstructive sleep apnea, we use CPAP. For COPD, we use BiPAP. Okay, next question. Growth hormone levels are high, but IGF-1 levels are low. What is the diagnosis? Simple, straightforward question. Parasin, yeah, I will give you 5 minutes and I'll try to help you how to approach the ABG questions. Growth hormone levels are high, but IGF-1 levels are low. See, normally from where the growth hormone comes? The growth hormone comes from your anterior pituitary gland. Now, growth hormone doesn't exert its effect directly, right? It acts primarily on the liver, right? So, on the liver, there are growth hormone receptors. So, growth hormone will bind to that receptor and make the liver secrete one more substance which is called as insulin-like growth factor 1. This insulin-like growth factor 1 will act on your skeletal muscles and your bone to cause tissue growth. Right? So the insulin-like growth factor is the one which is driving the growth of the tissues. Okay. Now in this case, what is happening? Growth hormone levels are high. Means this growth hormone is high, but IGF-1 level is low. In a physiological state, what should happen if growth hormone level is high? High stimulation of growth hormone receptors and high production of IGF-1. But here what is happening? This is high, but IGF-1 level is low. So the problem must be in the growth hormone receptors on the liver, right? So what should be the answer here? Option A, the growth hormone receptor defect. Okay. Now which of the following, look at the X-ray and tell me which of the following disease can present like this. What do you see on the chest X-ray? You can see multiple balls stuck in the chest X-ray, right? So we call it as cannonball appearance. Cannonball appearance. So cannonball appearance in any organ, particularly lung, means that the tumors from somewhere else have come and deposited in the lung. So obviously option B would be the answer. If it was a case of tuberculosis, what all I could have seen? Most commonly what I would see is apical fibrosis. Tuberculosis affects the apex of the lung, more common, right? So you would have seen apical fibrosis. The second thing I could have seen is the cavitatory lesion. Tuberculosis causes cavitatory lesions. I'm not seeing any of that. Otherwise, I would have seen miliary mottling or small fibrotic streaks. Miliary tuberculosis called as miliary mottling. So I don't see those changes here, right? If it is interstitial lung disease, we have discussed, right? We will see reticular opacities. And in HRCT, we would see something called as UIP or NSIP pattern, depending on what is the cause for ILD. We will be seeing those two patterns. I don't see any ground glass opacities or anything like that. If it is fungal pneumonia, right, it causes bronchopneumonia. So I will have patchy opacities, not well-defined rounded opacities like this, right? So here I can clearly see well-defined rounded opacities. That's why it is called as cannonball appearance. The moment you see cannonball appearance, it is metastasis to the lungs. Okay. Next question. A stonemason from Kota, Rajasthan, who works in stone breaking industry, has developed pulmonary tuberculosis. Which occupational disease is responsible for this? Again, a very straightforward question. Occupation is stonemason, right? He is a stonemason. Like, how many of you have Kota stones on your floors? Right now I have Kota stones on this building floor. Okay, they are a work of great artisan and craftsmanship, right? See, if it is an occupational lung disorder associated with increased risk of tuberculosis, what comes to your mind? Occupational lung disorder with increased risk of TB. There are two occupational lung disorders which are associated with increased risk of TB, and among them the highest risk of causing TB is silicosis. Silicosis is more commonly associated with TB than coal workers' pneumoconiosis. Asbestosis is not associated with increased risk of tuberculosis. It is silicosis and coal workers' pneumoconiosis, right? In fact, there is a term called as silicotuberculosis. So like a silicosis patient develops tuberculosis, we call it as silicotuberculosis. Silicotuberculosis. And stone exposure, stone breaking, obviously he would be exposed not to coal, right? Would he be exposed to coal? No, he will be exposed to the silica, right, from the stone. So obviously the answer would be silicosis. Silicosis. Okay. Can anybody tell me what other disorders, the risk of what other disorders is increased in patients with silicosis? So one more point to note, right? Silicosis is associated with increased risk of rheumatoid arthritis and SLE. Rheumatoid arthritis and SLE. Particularly remember rheumatoid arthritis. Silicosis increases the risk of developing rheumatoid arthritis. Yes, carcinoma of the lung risk is increased in most of the occupational lung disorders, silicosis, coal workers' pneumoconiosis, as well as asbestosis. But in silicosis, there is increased risk of rheumatological disorders because silica is called as an immunoadjuvant. Like see, when we give vaccine, we add aluminium or other substances which will make the immunogenicity of the antigens much more stronger. So same work silica does. So that's why there is increased risk of rheumatological disorders. Okay, now look at this question and tell me what is your diagnosis. History of NSAID abuse, presented with severe epigastric pain. You have the X-ray abdomen in front of you. That's an erect abdominal X-ray. What do you think is the diagnosis? There is an arrow pointing at something. What is it pointing towards? Right, the arrow is pointing towards the air under the diaphragm, right? Normally under the diaphragm there should not be air until and unless there is a perforation of any part of your intestine from where the air leaks. You will not see air under the diaphragm. So if there is air under the diaphragm, that means there is a hollow viscous perforation, air under the diaphragm. It indicates hollow viscous. Hollow viscous means your intestines, right, or the hollow organs. Hollow viscous perforation from where the air is leaking. And in this case, it becomes much more likely because the patient has history of NSAID abuse. So probably he would have developed a peptic ulcer either in the stomach or the duodenum, and that has now perforated, giving rise to air under the diaphragm. So option A becomes the correct answer for this question. Okay. In this question, we have a 41-year-old who presented with dry cough. Dry cough. On examination, there is clubbing with basal late inspiratory crepitations, right? Late or end inspiratory crepitations on auscultation. Spirometry shows restrictive lung defect with FEV1 of 60%. What is the diagnosis? Okay. Now, they have clearly mentioned that it is a restrictive lung defect. Now, what does that mean? That means the patient's FEV1 by FVC was more than 70%, right? So, if it is a case of obstructive lung disease, then patient's FEV1 by FVC would be less than 70%. Okay. Now, chronic bronchitis, is it an obstructive lung disease or restrictive? Chronic bronchitis is right. Chronic bronchitis is a obstructive lung disease. The emphysema of the COPD is a restrictive lung disease. Chronic bronchitis is an obstructive lung disease. Right. So that is one point which goes against the option A as the answer. There is one more point. What is that? Dry cough. Now, how do you define chronic bronchitis? Chronic bronchitis is defined as, it is defined as productive cough, sputum production, productive cough for more than or equal to 3 months per year for 2 consecutive years, 2 subsequent consecutive years. That's how we define chronic bronchitis. So cough should be there, it should be productive, and it should be for at least 3 months every year for 2 years continuously. Then we call it as chronic bronchitis. The moment you say that dry cough is the complaint, goes against chronic bronchitis, right? Then bronchiectasis. Bronchiectasis is also associated with productive cough, and it is also a obstructive lung disorder. Obstructive lung disorder, right? So we are only left with option C and D. Bronchogenic carcinoma, we don't fit it into obstructive or restrictive. It is a space occupying lesion, right? So we are only left with option C, pulmonary fibrosis, which indeed is a restrictive lung disease, right? So they are talking about idiopathic pulmonary fibrosis, which is the most common type of ILD. And in this patient on the HRCT, we get that usual interstitial pneumonia pattern. And the auscultation findings that we get here, right? The late end inspiratory fine crepitations, they are also described as Velcro crackles. Velcro crackles. So all fits into pulmonary fibrosis or IPF, and that would be the answer for this question. Yeah, in bronchiectasis, yeah, one more point, yeah. So in bronchiectasis, you will have coarse crepitations. Crepitations will be coarse, not fine like we are seeing here, and they will not be end inspiratory. In bronchiectasis, what happens is your small segment of the bronchial tree is dilated, irreversibly damaged, and there is accumulation of the mucus. So when air flows through this mucus, it produces bubbles, and we hear that as the crepitation. Now, During inspiration, air is moving, that will create a crepitation. During expiration, again air is moving out, that will also create crepitation. So when you have crepitations only in the end portion of inspiration, that again goes against the bronchiectasis. Yes, bronchiectasis, if it is cylindrical, you will have that signet ring sign and tram track sign on the X-ray or HRCT. Okay, which of the following is correct chest X-ray finding of COVID-19? The ground glass opacities are more likely encountered in silicosis. So in asbestosis, it causes extensive fibrosis. So you get UIP type of picture. Right. So in COVID-19, the most common HRCT finding was ground glass opacities. Right. So apical coin shadow should indicate or should raise the suspicion of a Pancoast tumor. Suspicion of Pancoast tumor, right? Apical consolidation should raise the suspicion of tuberculosis. Suspicion of TB, right? Peripheral reticular opacities should raise the suspicion of idiopathic pulmonary fibrosis. So ground glass opacities is what we would see in patients with COVID-19 and many other conditions. So it is not specific, but that is what is the most common finding on the HRCT in COVID-19 patients. Okay, now patient of COPD is on salmeterol and still has dyspnea on exertion. What drug will be given next? Can anybody answer this question? Patient of COPD is on salmeterol and still has dyspnea on exertion. See, do you remember how we approach the management of COPD? Right? In the management of COPD, we will pay emphasis on the history of exacerbations. That's the first thing in any question. If exacerbations are a significant problem, right, more than or equal to 2 moderate exacerbation in last 1 year or more than or equal to 1 hospitalization in last 1 year, we put that patient in category E, right? So please remember how to approach a case of COPD. COPD management. Okay, so first thing is that history of moderate exacerbations more than or equal to 2 in last 1 year, or history of hospitalization, that is severe exacerbation, more than or equal to 1 in last 1 year. If any one of them has happened, right, then we will put the patient in category E, right? E is exacerbation predominant category. Here, if like last year 2 moderate exacerbations have happened or 1 severe exacerbation requiring admission has happened, then that patient should go into category E. Okay. Now, if you say that no sir, not so many significant exacerbations have happened, right? If the answer is yes, the patient will go into category E. But if you say no, then he will go into either category A or B. Now to decide that, we have to look at the Modified Medical Research Council grade, MMRC grade. The grade can be either 0 to 1 or more than or equal to 2. If it is more than or equal to 2, the patient will go into category B, and if it is 0 to 1, the patient will go into category A. Now we will see how do we treat these categories, right? So if it is a case of category E, the exacerbation is a predominant problem and LAMA plays a very important role in reducing the exacerbation. So treatment should have a LAMA, plus for a good symptomatic relief, we will also give them a LABA. And in 2023 onwards, for category B also we follow the same treatment as LAMA plus LABA. LAMA plus LABA. But for a category A patient, we start the treatment with any bronchodilator. Any bronchodilator. So any bronchodilator means either LAMA or LABA. So now you tell me, looking at this question, which category this patient was belonging to earlier, right? Based like which category he was belonging to, so that this current treatment was started. Which category this patient belongs to? Which category? Probably he belonged to, because they have started only one medication, right? They have started salmeterol. Salmeterol is a long-acting beta agonist. They have not started tiotropium here, so they have not started LAMA. They have only started one medication, that is LABA. So it was a category A patient. Now if the symptoms are still not controlled, then what is the choice that I have to add? They have already started a LABA, right? Here any bronchodilator was a choice. We have started a LABA, it is not helping. Now naturally he should progress to category B treatment and we should introduce a LAMA, right? We should introduce a LAMA. So where is the LAMA here? LAMA is option C, tiotropium, right? So please remember, we have ipratropium, which is a SAMA, short acting anti-muscarinic agent, which is used in acute conditions, and tiotropium, which is LAMA, long acting anti-muscarinic agent, which is used for a regular management, right? Again, easy to remember. When you look at the alphabetical orders, I comes first, right? So short acting. T comes late for long acting. Okay, next question. I'm sure you will be able to answer this. The patient went for THR. THR stands for total hip replacement after fracturing his neck of femur. After 7 days, he presented with breathlessness. What is the diagnosis? What is the most likely diagnosis here? Venous thromboembolism, air embolism, or fat embolism? Okay, how many of you think it is fat embolism and how many of you think it is venous thromboembolism? Which one is more common, fat embolism or thromboembolism? Paritosh, yeah, we will address that. What is more common? Thromboembolism is more common than fat embolism. Fat embolism is relatively rare. Okay, and then fat embolism, from where the fat is coming? From those bones where there is dense marrow, right? Less dense marrow, bones with less dense marrow are less likely to cause fat embolism, right? And fat embolism is relatively rare. Second thing. Then the third thing you should remember here is that as you age, right, with your aging, the marrow starts shrinking in size, it starts getting fibrous, and the quantity of fat in the marrow also comes down. So an elderly is less likely to develop the fat embolism in comparison to an young individual. And I can tell this with the experience of having a fracture and having gone through fat embolism. I can relate to it. Like young individuals having good amount of marrow fat are more likely to develop fat embolism. Now, which patient you will offer a hip replacement? If I develop a fractured neck of femur, you would go for hip replacement, or an elderly person developing the fractured neck of femur, that you will go for hip replacement? Obviously, it is an elderly. Elderly are at lower risk of developing fat embolism. Elderly are at increased risk of developing the venous thromboembolism. Right. Now, if you have done a hip replacement, don't you think you will be immobilizing the patient and he will be bedridden for quite some time? Right. And when it happens, right, when you immobilize, there is a risk of developing DVT. So this patient has various risk factors for developing DVT. Right. This patient has various risk factors for developing DVT. One of them is age. Though they have not mentioned, because they have gone ahead with a hip replacement, I would think that it is an elderly patient. Second, prolonged immobilization after the hip replacement. And third, right, remember, when post-surgical thromboembolism happens, the most common site of surgery will be the pelvic region. Means whenever pelvic surgeries happen, like if you are doing some hysterectomy or some pelvic surgeries, or you are doing surgeries on the lower limb or the hip joint, that is where the highest risk of thrombosis and embolism is there. So total hip replacement is in fact a very strong risk factor for development of thromboembolism. So keeping all this in mind, right, we should go ahead with the venous thromboembolism and not fat embolism. And please remember here that when we make a diagnosis of a rare disease, we are rarely correct. So always stick to commonality first rather than rare. Fat embolism is a second possible differential diagnosis. First will be venous thromboembolism. And if I have to commit to the diagnosis of fat embolism, there should be some additional clues saying that urine fat globules are positive or something like that. That information is not there in the question. So keeping the commonality rule in mind, I will go with option A as the answer. Okay. Continuing with the same thread, investigation of choice for pulmonary embolism. What would be the investigation of choice? Right, Yogesh Shruti. There should be either urine fat globules test should be positive or a lipiduria. Some additional clues they would give if they want you to diagnose fat embolism. So we are talking about pulmonary embolism. That means a clot formed in your venous circulation goes to the right atrium. From the right atrium goes and gets stuck in the pulmonary artery. Right. So I have to identify a clot stuck in the pulmonary artery. What would be the best investigation? Can I identify the clot in the pulmonary artery with the USG? Obviously no, I can't see the pulmonary artery with the ultrasound, right? Can I do Doppler for the pulmonary artery? No, Doppler is not the answer, right? So Doppler is for DVT, not for the embolism. I can see the peripheral veins, right? Lower limb veins with the Doppler scan. I can't do the Doppler scan for the pulmonary artery, right? So the investigation of choice would be CTPA. CTPA stands for CT pulmonary angiogram. Pulmonary angiogram. So that would be the investigation of choice. Okay. If CT pulmonary angiogram is not possible, subgroup 18, what is your point? Like 2 to 3, DVT won't happen or the embolism won't happen after 2 to 3 days? Or you mean, yeah, the fat embolism happens usually 3 to 4 days after the fractures, not beyond that. But that is the time sufficient enough for the clot to form. Immobilization of 7 days is good time for a clot to form and embolize. Okay, CT pulmonary angiogram would be the investigation of choice. They will ask you one more question. If CT pulmonary angiogram is not possible, because for pulmonary angiogram you need to give contrast. If patient has got CKD or already his kidney functions is gone for a toss, it may be a problem. In that case, what would be the investigation of choice? It is the investigation of choice. Alternative for CT pulmonary angiogram. What else we can think of? Right subgroup. So what else you can think of? Alternative, you can do VQ scan, ventilation perfusion scan. Means some area of the lung is getting good air but not getting good blood flow, means the blood flow to that area is blocked. The ventilation perfusion scan or VQ scan is an alternative for CTPA, but the investigation of choice or a gold standard would be CT pulmonary angiogram. Okay, next question. Patient of mitral valve disease started on warfarin for enlarged left atrium. Why should we start warfarin for Medicuric? I didn't get your point. VQ scan infinity, I didn't get your point. Yeah. Okay. Why should we start warfarin for an enlarged left atrium? So please remember, enlarged left atrium is associated with increased atrial fibrillation risk. Okay. Now atrial fibrillation risk means that there is a risk of forming a left atrial clot. The clot can go to left ventricle and cause the embolism, right? What embolism? Systemic embolization. Means the clot will go into the aorta, from aorta most likely carotid artery, from carotid artery most likely MCA, and cause stroke. That is why atrial fibrillation is associated with increased risk of stroke. Okay, so that's why we have started warfarin. Now please remember, whenever patients have rheumatic heart disease or patients have prosthetic valves, we still use warfarin as the anticoagulant of choice. If it is non-rheumatic and no prosthetic valve and some other cause, there is increased risk of atrial fibrillation, we can use newer oral anticoagulant. They would be preferred agent, right? So please remember, warfarin is the drug of choice in case of rheumatic heart disease and prosthetic valves. In these cases, if you need to give anticoagulation, that to particularly metallic prosthetic valves, the newer bioprosthetic valves, you can still use the newer anticoagulants. What should be the INR? The INR level should be 2 to 3. 2 to 3. If you go more than 3, you need to cut down the dose. If you're less than 2, you need to increase the dose. 2 to 3 is the range of INR where you have a good anticoagulant efficacy with minimal risk of bleeding complication. Okay. Next question. Which murmur is shown in the image below? Is it ejection systolic murmur, pansystolic murmur, early diastolic murmur, or late systolic murmur? The murmur is heard between S1 and S2, right? Whatever happens between S1 and S2 has to be systolic. Between S2 and S1 is diastolic. So it has to be a systolic murmur. So I will rule out early diastolic murmur with confidence. Okay. Now, is it ejection systolic, pansystolic, or late systolic murmur? Okay, I'll tell you why is it not pansystolic. So if it is pansystolic, the murmur starts with S1 and ends with S2, right? Here I can say that it is ending with the S2, right? It is merging with the S2, but it is not starting with the S1. You can see a gap. S1 happens, there is a gap, and then the murmur starts. So it can't be pansystolic. If it was pansystolic, it would start with the S1, continue to S2. So S1, murmur, and S2 all will be merged. But you can notice a gap there. So it is not pansystolic either. It is certainly not late systolic. Late systolic means only later part of the systole you would have seen the murmur. So it is not late systolic either, right? This is the image classical of ejection systolic murmur. So basically what is happening here is after S1, you have this isovolumetric contraction phase where the murmur is not heard. And after the isovolumetric contraction phase, the murmur starts, right? That's why it is called as ejection systolic murmur. And you can see this classical diamond shaped murmur. So if this murmur is heard from the aortic area, that is a very classical example for aortic stenosis. And if the same murmur is heard from the pulmonic area, that would be a classical example for pulmonic stenosis. This is a ejection systolic murmur. And what do you call this as? Crescendo, increasing intensity, and then decreasing intensity, crescendo, decrescendo murmur, right? So examples for ejection systolic murmur. One is aortic stenosis, second one is pulmonic stenosis. Okay, next question. An old man presented with complaints of breathlessness and occasional episodes of chest pain. General physical examination shows high volume pulse, right? High volume pulse. The BP is 150/70. On cardiovascular examination, apex beat is displaced 1.5 centimeter lateral to mid-clavicular line. On auscultation, diastolic murmur is heard. What is the diagnosis? What is the diagnosis? Can it be a case of aortic stenosis? No, right? Why it can't be a case of aortic stenosis? In aortic stenosis, the pulse becomes low volume, right? Slow rising, late peaking pulse. What you call it as pulsus parvus et tardus. This is not the case, right? Second, what will happen to the BP in aortic stenosis? The systolic BP in aortic stenosis will come down. What we call as systolic decapitation of blood pressure. That is not happening here, right? It can't be a case of AS. Can it be a case of AR? In AR, what all changes we will see? In AR, the stroke volume is increased, right? But there is a decreased diastolic circulation because diastolic there is backflow. So during the systole, increased flow forward, during diastole, all going back. So systolic blood pressure increases, diastolic pressure decreases, right? When systolic increases and diastolic decreases, what will happen to the pulse pressure? In AR, systolic BP increases, diastolic blood pressure decreases. So what will happen to the pulse pressure? Right, pulse pressure becomes wide, right? How do you define pulse pressure? Pulse pressure is equal to systolic BP minus diastolic BP. So if the systolic increases and diastolic decreases, the difference between the two will increase. So the pulse pressure in aortic regurgitation would be increased. Okay. So here what is happening to the pulse pressure? 150/70. What is happening to the pulse pressure? The pulse pressure is 50 plus 30, right? So it's like 80. Pulse pressure is 80. Clearly, the pulse pressure is increased. Pulse pressure here is 80. Pulse pressure is increased. So that is first point that goes in favor of the aortic regurgitation. High volume pulse happens in aortic regurgitation and also mitral regurgitation. Those two are differential diagnosis. The right-sided pathologies, right? Tricuspid insufficiency and pulmonary insufficiency will not cause your peripheral abnormalities, because whatever happening right side abnormalities will cause the impact on the lungs, not on your systemic circulation. So we have to mainly differentiate between A and B, aortic regurgitation and mitral regurgitation. Can both of them cause displacement of the apex beat? Can aortic stenosis cause displacement of the apex beat? No. Aortic stenosis, what happens is, in aortic stenosis there is concentric LVH, and when there is concentric LVH, more muscle mass is added inside the ventricle. Ventricle side doesn't grow much outward, so apex beat will not be displaced. But in AR, and MR, right, there is eccentric LVH, or in other words, there is dilation of the left ventricle. There is dilatation of the left ventricle. So that is why when left ventricle dilates, your apex beat will be displaced. So this can lead to displaced apex beat. So both are possibilities, right? Now if it is a mitral regurgitation, what murmur I will get? If it is mitral regurgitation, will I get a systolic murmur or diastolic murmur? So first point, the wide pulse pressure is already going in favor of aortic regurgitation. Displaced apex beat can go in favor of both. Now I have to decide between these two primarily based on the murmur, right? So yes, so in mitral regurgitation you will have a systolic murmur. Systolic murmur. If it is a acute mitral regurgitation, you will have a early systolic murmur. If it is a chronic mitral regurgitation, you will have a pan-systolic murmur. But murmur, whether acute or chronic, will be systolic. In aortic insufficiency, there will be a early diastolic murmur. Early diastolic murmur. So keeping the murmur nature in mind, we will go ahead with option A as the answer. Aortic insufficiency would be the answer here. And everything else fits into it, because the shortness of breath can be explained by aortic insufficiency. Occasional episodes of chest pain can also be explained with aortic insufficiency. Okay, next, a patient was asked to copy a clock face by the physician. Image on the right is made by the patient. What is correct about this image? Right, like the similar patient, we had seen a real life image in our offline classes, right? This is a classical picture of hemi-neglect, because the patient has neglect of one side of the visual field, right? He has absolute neglect, is unaware of it, so he will not be able to sketch the components on the other side, right? The same patient, if there is no caretaker for the patient, you might also notice that they're not taking care of their one side of the body. This is what we call as hemi-neglect, right? Now one last question. This is a simple answer, but where do we see that? It is due to lesion of non-dominant parietal lobe. Lesion of non-dominant parietal lobe. Okay. Now apraxia and agraphia, they are usually seen with Gerstmann syndrome, which is due to lesion of which area? Called as due to lesion of angular gyrus on the dominant parietal lobe. Angular gyrus on dominant parietal lobe. Hemianopia, you have studied plenty of locations of visual defects depending on where is the site of damage, from optic chiasm to the optic radiation to visual cortex. So I will leave it to ophthalmology. Yes, so there are multiple A's there. Agraphia, alexia, right? Then 𝐒𝐿𝐶𝐝, all of that. Okay. And also the left-right confusion. Patient presents with hand enlargement with gynecomastia and lactation. Where is the tumor located? Enlargement of hand with gynecomastia and lactation. Where is the tumor located? Okay, see, what are the hormones produced by the posterior pituitary? Hormones produced by posterior pituitary. Posterior pituitary produces oxytocin and vasopressin. Do they have any role in the symptoms mentioned here? Do they cause head and hand enlargement? Do they cause gynecomastia or lactation? No, right? Oxytocin only plays role in parturition or labor. Vasopressin plays role in regulation of your blood volume, vasoconstriction, right, and ACTH secretion. So they are not directly related to any of the symptoms. So this is first thing that I can rule out. Okay. Adrenal gland pathologies can explain gynecomastia, because excess production of adrenal androgens, then they are getting converted to estrogen and that causing gynecomastia, explainable. Or adrenal gland dysfunction, explainable, but other symptoms cannot be explained with adrenal gland disorder. So that is ruled out. Okay, now we have to choose between anterior pituitary and hypothalamus. Okay, which hormone can cause enlargement of head and hand? Which hormone can cause enlargement of head and hand? We have heard the term acromegaly. Acral means hands and feet, right? Acral enlargement is acromegaly. And all this prognathism, yes. So these can be explained with growth hormone. But can growth hormone explain the lactation or gynecomastia? Can growth hormone explain gynecomastia? Growth hormone indeed can cause, but less likely, right? Lactation I can explain with prolactin, right? Gynecomastia I have to relate it to, yes, as you said, maybe growth hormone in a very high quantity may cause gynecomastia, but less common, less likely. So I have to explain the condition by looking at prolactin elevation, growth hormone elevation, and also imbalances with FSH, LH. So if all of them are getting affected, from which structure all of these hormones are coming from? Pituitary gland, right? But have you heard of a condition where pituitary gland start producing multiple hormones, or a pituitary tumor producing multiple hormones? Unlikely, because pituitary tumors are monoclonal in origin. Means prolactinoma produces prolactin, somatostatinoma produces the somatotropinoma produces growth hormone, TSHoma produces TSH. They are monoclonal. They don't produce multiple hormones. So if you are seeing multiple hormones in excess quantity, the problem must be in the hypothalamus. The hypothalamic hamartoma may be the reason for pituitary trying to produce multiple hormones. So we have to place the answer at hypothalamus. So please remember one statement, right? Pituitary tumors are monoclonal. Monoclonal. So if a tumor originates in the pituitary gland, it originates from only one secretory cell type, not a combination of growth hormone producing, prolactin producing, TSH producing, prolactin producing tumors. No, right? Yeah, so there is a hypothalamic tumor which is producing multiple tropic hormones which are stimulating the pituitary gland to produce multiple hormones. That is the explanation. So hypothalamus would be the answer. Okay, this is a straightforward question. A chronic alcoholic is having diarrhea, dementia, dermatitis. Which vitamin is involved? B1, B3, B6, B12. 3Ds, we all know it is due to what? This is a case of pellagra, right? Pellagra, which is due to niacin deficiency. Right, so we will go ahead with the option B. Okay, next. Though it is a pediatric question, we'll still answer this. A child from low socioeconomic status is brought with complaints of fever and abnormal behavior for 3 months. Child, remember here, the duration is 3 months. Child has been in an altered sensorium for past 1 week. On examination, neck rigidity is there and CSF is showing increased lymphocytes. Glucose is 30 mg/% and protein is 300 mg. Protein, see, normal CSF protein is around 45 or less than 45 milligrams per deciliter or percentage, right? Normal glucose is 2/3 of plasma glucose, right? And cell count should be less than 5. That's your normal CSF picture. So first thing, can I think of bacterial or viral meningitis in this case? No. Why? Because it is a case of chronic meningitis. It is not acute. So I have to mainly think of tubercular meningitis. My differential diagnosis will be TBM and fungal meningitis. Okay. So between these, from the history, I would strongly think of tubercular meningitis. Why strongly think of tubercular meningitis? Because it is a child from low socioeconomic status. Instead, if they had mentioned that this is a case of cancer who is on chemotherapy, or it's a case of HIV, I would have thought of fungal meningitis, right? So history gives us some clues towards the diagnosis. So from the history, I am already leaning towards tubercular meningitis, and the CSF picture fits into it. Lymphocyte predominance and low glucose. See, even if I take the patient blood glucose as 90, still it is less than 2/3, right? Even if you take it as 80, it is still less than 2/3. So significantly low glucose again goes in favor of tubercular meningitis. So answer would be tubercular meningitis. In fungal meningitis, such low glucose you won't see. That is the important point. Low glucose, low socioeconomic strata, chronic meningitis, lymphocyte predominant, so that would be counted as tubercular meningitis. Okay, so this question we have already done, so you know what is this case. It is about the management now, right? So here is a patient with someone presenting with acute abdominal pain. X-ray is done. What we see here is the air under the diaphragm. Now how would you manage next? So whenever we see air under the diaphragm, we know that there is a perforation of an internal viscus, means your intestine, large or small intestine is perforated. How would you treat further? Right, the answer would be, you need to take this patient to operation theatre, open the abdomen and see where is the perforation and surgically solve the problem. It is an acute emergency, it's a surgical emergency. So an exploratory laparotomy would be the next best step. It will tell you, once you open, you will see where is the perforation, and then you can decide what would be the surgical management for that level of perforation. Okay, now what this imaging shows, pretty straightforward, right? So we all know that this imaging is showing clubbing. Clubbing, we can see neatly clubbed fingers. Okay, let us see this image now. What is the likely diagnosis of this case given in the image below? What all you will notice? You will notice that first thing that comes to your mind is that there is obesity, right? Doesn't look like the person has gone to the gym and accumulated such muscle mass. It clearly looks like there is obesity, right? Second thing we will notice here is that there are pink purplish striae, right? Pink purplish striae. The third thing you will notice that there is gynecomastia. Then fourth thing you might notice here is that, what do you call this as? Buffalo hump. Buffalo hump, the fat pad on the neck. Okay, what else you will notice? Here and here there is bruising. Right, all of these are pointing towards what this is. All of them are suggestive of Cushing syndrome. So this image is a case of Cushing syndrome. Yeah, moon face also. Moon face, Chand se roshan chehra. Okay. The hepatitis profiles, I will leave it to microbiology, because all the hepatitis questions will be addressed in microbiology. I think this is what we had for today. Now many of you have queries, so please raise those queries to me on the Telegram, so that the queries will also be useful for all other Telegram members. I will address it there. And till the exam, daily between 7 to 8, I will be available on the Telegram free. So any personal queries, be it academics or be it non-academic queries, you can ping me on the Telegram and we will take it from there. And PW has put up a schedule for other subjects also starting from tomorrow. So tomorrow Dr. Dharmendra is doing psychiatry, and then on 9th Dr. Ranjit is doing pathology, and other subjects will be followed. So stay tuned, and I will assure you that whatever we are going to cover in these sessions are only the extremely important questions or extremely important topics, and not the ones which are like new addition of information. So you will not be burdened with information, rather it is going to be a quick revision of crucial points. Okay, 7 to 8 p.m. daily I will be free on the Telegram, so any queries you can ping me there. Okay, so I'm signing off guys now, and I'll be in touch with you till the exam, and we will continue our learning. Thank you all. Thank you.